students. Welcome to Module 1, Fluid and Electrolytes. I'll just be brief here with my voice over PowerPoint so you can start to get used to the technology that you'll be encountering in your online classes. And since we'll have already discussed some of this in class. Why is it important to understand the movement of fluid within cells and among cells? Well, it's fundamental to understanding pathophysiology. It's critically important to understand how fluid is integral to understanding how our cells are nourished, they interact with the environment in wellness and in health. So oftentimes we'll look at situations which is a normal physiological event, and then we'll see how disease alters that normal physiological event. And then even at times we'll talk about some pharmacology. And when we talk about pharmacology, we'll talk about how the body automatically responds to the illness, and then how we use inherent systems within the body and alter them somehow pharmacologically. And then another key point here when we talk about fluid and electrolytes is that abrupt changes in fluid volume result in electrolyte and blood pressure variance. What does that mean? Well, for instance, what is blood pressure? That is fundamentally important to understand. It is the pressure, the hydrostatic pressure of water or fluid, plasma for instance, being exerted against the vasculature. And understanding how this hydrostatic pressure works and has its own entire properties is critical to understanding issues such as hypervolemia, where there's high levels of pressure, hypertension, where we have levels of hypovolemia, such as dehydration and loss of systemic blood pressure. So understanding all of that is really important, and we'll look very closely at issues around that today. First, you must understand that there's an intracellular compartment and an extracellular compartment. The intracellular compartment consists mainly of all the fluid contained within within cells in the body. It is the larger of the two compartments, with approximately 2/3 of the body water in healthy adults, believe it or not. And it's really important to remember is the ionic relationship between intracellular and extracellular space. As I was taught at Simmons College in my pathophysiology course many years ago by a Harvard student, although marijuana has been legalized, so it doesn't apply entirely. But if you remember that it's important to keep your pot in the house, and you'll always remember that the relationship of potassium is within the intracellular space, and sodium being the chief electrolyte outside of the cell. In water, sodium is always, of course, intricately allianced with water. Then the extracellular compartment contains the remaining 1/3 of the body water, and this is all the fluid outside of cells, particularly those in the interstitial tissue spaces and in the blood vessels. And that's important to remember when we talk about drawing bloods, for instance, for potassium or potassium levels is a good example. When we draw blood, we're drawing blood from the extracellular compartment, and we're getting some number back, some number. Most nurses know that normal potassium is somewhere between 3.5 and 5 MEQs per liter, correct? But when we look at that extracellular level, we are actually making assumptions of large amounts of potassium that are actually intracellularly. You understand? We're making assumptions based upon this calculation of potassium in the blood, the extracellular space, and what the normal levels should be intracellularly. So these becomes important concepts when we look at illness down the road. So I'm not going to talk about this slide. We'll move to the next one. Other issues that we need to look at are issues of tonicity. And tonicity refers to whether cells, basically whether they'll shrink or whether they'll shrink or they'll swell. And isotonic means that they remain the same size. Hypotonic means that I think of this as swelling. The cell will actually swell in response to fluid distribution. I think of this in terms of hypodermic needle, and that's how I remember hypo makes cells swell, because you can actually, for instance, like put a needle in there and sort of make it inject fluid into it and make the cell swell. And then in situations where the area around the cell is hypertonic, you'll actually have the cell shrink. So review here, largely sodium and chloride constitute 85% of the extracellular fluid space. Potassium lives largely intracellularly. It's maintained by a sodium-potassium channel, which is active transport requiring energy. And serum ECF concentrations are what we draw, ECF blood, are areas that we draw blood from to make assumptions about what's actually occurring intracellularly. Now, I'm not going to go through all of this here. You should be somewhat familiar from past sciences of what diffusion means. Filtration is referred to as a water pushing force. I like to think of glomerular filtration that occurs in the nephron as an example of filtration. It's basically hydrostatic pressure. It's the force per unit area exerted by liquid at rest. Important to think about. I think everyone here probably knows what active transport is. Osmosis is water pulling force. Osmolarity and osmolality. Basically, I rarely use the term osmolality. It is a term that some people will use occasionally to kind of confuse you. But primarily, you just need to look at osmolarity. And if you think of osmolarity, just think of solute concentration in a solution. Increasing solute in a solution means that there's less water. Increasing osmolarity means increasing solutes, so you have actually less water. These conditions are typical with, for instance, dehydration. And you'll have an increased level of antidiuretic hormone in response to that, and we'll get to that in a little bit. Decreasing osmolarity means that there's more water and less solutes. This is a concept you should really become quite fluent with, and we'll talk a lot about during this semester. It's the osmolarity that actually determines the tonicity, whether cells will shrink or whether cells will swell. So here's a situation where we have an isotonic relationship. Here the fluid surrounding the cells, the extracellular fluid space, is isotonic. There are no fluid shifts between the compartments because each of the, for instance, there's enough sodium in the same amount of sodium inside the cell as there is on the outside. The ECF is matched with the ICF. Here's a condition where which we refer to as hypotonic. Here, the ECF has a lower water and solute concentration than the ICF. Can you see that? There's more sodium ions inside the cell than there are on the outside. So this fluid shift is from the extracellular fluid space into the intracellular fluid space. Water moves in towards the cell to neutralize the tonicity. The cells swell and the plasma volume contracts. As I said, think of a hypodermic needle injecting fluid into the cell, adding more water ions to neutralize the 3-to-1 relationship. Increased solute in this cell will draw water in to the cell, and the cell will actually swell, as is depicted by this red mark here. Let's go ahead here. And then the opposite is true. When the fluid in the extracellular space has a higher water solute concentration than the outside of the cells, as marked by this increased number of sodium ions on the outside versus only one in the inside, fluid shifts from the ICF into the ECF. The plasma volume expands. The cell shrinks. You actually end up with an intracellular dehydration. As you see how the water moves out of the cell. In this case, because there's more solute in the ECF water will move out until the cell swells. Cells often swell here. Cell will get much, much, much bigger. Excellent. So we talked earlier about hydrostatic pressure. Hydrostatic pressure is fluid or hydro pushing or movement, static. Refers to the pressure of fluid exerted against the vascular walls, capillaries, arteries, veins, etc. Hydrostatic pressure determines which way fluid will shift. When the hydrostatic pressure in the capillary is greater than that in the interstitial space, fluid will move out of the intravascular space and into the interstitial spaces, as we'll see in the next slide. Here's a relationship between the interstitial space, tissues, and inside the capillary, inside your vasculature. So when the pressure in here is, say, for instance, 90 millimeters of mercury, and the pressure here is only 30 millimeters of mercury, fluid will move from this intravascular space into the extracellular space, this interstitial space. Actually, this is all ECF, right? But it'll move from the capillary out into the interstitial space. And that happens quite often at the arterial end. That's how cells get nourished. And then, as you'll see in the next slide, I call this the hose and bucket module. Here you have the arterial end, which is much smaller in diameter, lumen. And here again, as I said, for instance, maybe it's 90 millimeters of mercury at this local level. And then it reaches the capillary, and the fluid will move because this is 90. This is only 30 millimeters of mercury water pressure here. Now, over here we have the venous end. This is what I call the bucket, or the venular hydrostatic pressure. Much wider lumens in your veins. And here, the hydrostatic pressure moves fluid back into the space, because this is much lower. This is only 10 say for instance 10 millimeters of mercury. So fluid will move from this 30 back into 10. So that's actually how your intravascular system nourishes cells, by moving fluid out and then retaining it and grasping it back and then sending it back onto the rest of the vasculature. So again, I refer to that as a hose and bucket theory model. It's just my little thing, but it explains a lot. For instance, if this pressure here was not maintained, and this pressure here was not maintained, for instance, say you had a tortuous vein, and this pressure now is 110 millimeters of mercury. Where's the water going to go? Right, it's going to be sent back out here, and it's going to remain here in what we know as edema. So pathology can change this relationship between the hydrostatic pressures at the arterial end and at the venous end. So it's important to kind of understand this relationship. We call this relationship a special Starling's forces, because within this hose and bucket model, if you will, there's a capillary hydrostatic pressure, which I referred to. Then there's an intravascular colloid osmotic pressure feature, an interstitial fluid hydrostatic pressure, and an osmotic force from interstitial proteins. Well, that's a lot of words. Let's go back and see what that means. I talked earlier about the arterial hydrostatic pressure. That's the pressure coming in from the arterial end, usually a high pressure system. Then, within the blood vasculature, we have albumin, which is a large protein. And albumin is like a water magnet. You want albumin to stick to water as it does. And if you do, then you'll maintain your volume pressure here. If you have low levels of albumin in the blood, then you have less vascular pressure because there's less albumin to hold onto the water, and it will actually leak out. Such is a good case of this patients with liver disease. They have ascites. They have lower lymphedema because they don't have enough albumin to hold on to their fluid in their intravascular space, so it leaks out into the edema or into the peritoneal cavity. So the plasmoid colloid osmotic pressure is important. Oh, and what I didn't mention here is there are also some interstitial proteins out here, but usually not as much. Not as many interstitial proteins out here to exert a massive force of fluid volume, unless, of course, you have burn patients where they lose their intravascular tone and proteins leak out. Those are unusual circumstances. But so there's a little bit of interstitial fluid volume draw as well, as we saw, that 90 to the 30, and then at the venule end, that 30 back to the 10. All this is necessary for fluid movement. Otherwise, you end up with edema. Other factors which influence fluid balance are important. Of course, the kidneys, of course, monitor your intake and output based also upon your blood pressure. The renin-angiotensin cycle you should really get to know as well. Renin is released at times when one needs vasoconstriction, and angiotensin is a potent vasoconstrictor. Aldosterone, I usually think of, it sounds Italian to me because you want to salt the water in your pasta. So aldosterone is important for sodium and water retention. And at times when you have low hydrostatic pressure in your vasculature, you would want increased levels of aldosterone for sodium to bind more with water and to increase the amount of water in the vasculature. So the kidneys will respond by increasing sodium and water reabsorption and therefore restoring blood pressure. Antidiuretic hormone, or ADH, is also an important feature in times with dehydration. It prohibits the diuresis that would further cause decreased vascular volume. Antidiuretic hormone. We're not going to spend a lot of time on HO natriuretic peptide at this point in time. So as I said, you can just review this. The kidneys, the renin-angiotensin cycle, aldosterone, very important. Antidiuretic hormone, extremely important. We'll talk a lot about that this semester. These are some examples of fluid spacing. First spacing, no one ever talks about it because it's the normal deposition of fluids, as I showed you, with 2/3 of the fluids in the ICF and 1/3 in the ECF. Second spacing occurs when there's a violation of those Starling's principles, where you start to have excess accumulation of interstitial fluid, otherwise known as edema. Third spacing is fluid accumulation in areas that normally have little or no fluid. For instance, ascites in a patient with liver disease. Fluid extravasation into your joints, for instance. There's little or no fluid there. Those would be examples of third spacing, always associated with pathology. So the few things we wanted you really to understand in this module is volume excess and hypervolemia. And then the contrary, of course, is hypovolemia. So with hypervolemia, there are two types, isotonic and hypotonic. And hypervolemia really refers to the excess amount of ECF fluid in the interstitial and vascular cavities. In other words, it causes an isotonic overhydration. And typically, unless patients are renally repaired, you have compensatory mechanisms within your body that will adjust and prevent hypervolemia, i.e. you'd have less production of antidiuretic hormone, you'd have less production of aldosterone, sodium and water retention, and you'd have increased glomerular filtration, i.e. increased urine output in response to this hypervolemia. Another case of hypervolemia is, like, for instance, fluid overload, otherwise known as water intoxication. just another example of hypervolemia with increased hydrostatic pressure. The serum osmolarity in this case with water intoxication or water overload would actually decrease. All three compartments swell in this case, and you end up with a dilutional electrolyte deficits. Signs and symptoms of hypervolemia include tachypnea, or increase in respiratory rate associated with shortness of breath. You also have a rapid bounding pulse, jugular vein distension, orthopnea, difficulty breathing sitting up, hypertension, acute weight gain, edema, and a third heart sound due to a failing ventricle with increasing pressures in the ventricular space. And most importantly, crackles or rales in the lungs. Diagnostic aids with hypervolemia include chest x-ray. You can actually see fluid levels and or cardiomegaly associated with this. It's important to note that the hematocrit would be low. Remember, hematocrit, actually let me do this. Remember, hematocrit is, if this is a tube or a cylinder, if you will, imagine this is a cylinder of blood. In a euvolemic person, someone who has normal relationship, for instance, to their ICF and their ECF, hematocrit is a percentage. Hematocrit is a percentage of red blood cells in the plasma. This is plasma we have in the tube here. So, in a normal person, for instance, you would have a relationship that this would be your plasma, and say this would be your, in a male, say 45% of your RBCs. Okay, so the plasma contains 45% RBCs in a euvolemic patient. Now, the same patient, if we were to deprive them of fluids, it would obviously be a little lower in the, but you would have much less plasma. Can you see that? Because they're dehydrated. They're dehydrated. So what would be the percentage of their red blood cells per plasma? It'd be much higher. It'd be 60. So with cases of dehydration or hypovolemia, you have an elevated hematocrit level due to hemoconcentration. And then, of course, the opposite is true. Can you do this? Can you draw someone who is overwater intoxicated? Oh, of course. There, they've got a lot of plasma. What's their hematocrit going to be? Probably 30%. So this is someone with hypervolemia. And sometimes you can make the same assumptions about electrolytes. Not always, but sometimes. But certainly, one of the first clues to dehydration is hemoconcentration of the hematocrit. So it's an important feature to think about. Sorry, I'm still getting used to this myself. Oh, back up. Back up. So, with hypervolemia, as I said, hematocrit will be low, hemodiluted. You'll have pulse oximetry, may or may not be decreased. Most likely, it will be decreased if they're tachypnic and short of breath. And as I said, the electrolytes may be normal or hemodiluted. Now, the next case scenario is much more common, I would say, hypovolemia. And again, here I've given you a chart of the intracellular space, which is 70% total body water, to the 20% which is in the tissues, interstitial, and then 10% which is in the vascular space. This represents the extracellular compartment. This is a normal relationship, right? So remember this relationship, 70-30. When you have isotonic hypovolemia, what actually happens is you have shifting in the extracellular space, as is evidenced here. It was 10, it's now 8. It was 20, it's now 10. But the intracellular space stays the same. This is isotonic hypovolemia. This is garden variety dehydration. This is you, if you're healthy, and you have the flu, get out of bed, you feel a little dizzy, you go to the refrigerator to get something to drink, and you still feel really, really dizzy. This is what's physiologically happening. Okay, so treatment for this is restore the blood in the restore fluid in the vascular space, and then these two will self-regulate. So the treatment for this is either oral hydration if they're able to, or parenteral fluids. Very important to check orthostatics in these patients. Very, very important to check orthostatics. If the systolic blood pressure and the diastolic blood pressure, DPP, and heart rate are absolutely necessary to make a proper set of orthostatic vital signs. You have to, it's your peanut butter and jelly. You need both of them. Check them standing. I'm sorry, actually, you should do sitting, then standing first, number 1, and number 2. If a lying or sitting blood pressure is 120 over 80, and a heart rate is 80, and then you sit them up, or better yet, you stand them. I like to sit them first because if they're going to lose their pressure, I'd rather have them sitting on the bed, but you get the idea. If someone is truly dehydrated, they will lose at least 750 cc's of fluid, and it will be reflected in their blood pressure. Their systolic blood pressure will drop at least 20 points to, for instance, 100 over 80, and their heart rate will increase by 20 points. This is the basis for orthostatic. They can get lower, of course, but this is the basis, that the systolic blood pressure drops by 20 points and the heart rate increases by 20 points. If indeed you get this feature, a patient needs at least 750 cc's. Can they orally take it? Maybe they can. Give some Gatorade. If they are not able to eat or drink, then you'll need to certainly give them some parenteral fluids. This is a free trick, tactic. It should be done on just about every patient who suspect hypovolemia. The only people that it does not work on are your diabetics, because they have autonomic neuropathy, and they may be subject to this phenomenon anyway just by virtue of their diabetes, and or patients who are beta blocked. Patients who have beta blockers will not have this reflexive increase in their heart rate. Those are about the only patients that don't respond to this modality. So the next type of dehydration that occurs, which is sort of rare, second common cause of dehydration, usually occurs due to, for instance, metabolic acidosis, as in diabetes, the DKA. We'll talk about that as we progress this semester. But again, here's your 3 chambers. Here's your ICF, which is was 70%, is now shrunk. In response to this hypovolemia that we had earlier, that maybe we never really rectified, or it got worse, now we need to draw on the ICF to fill the ECF. So the movement is from fluid from the ICF into the ECF. And this requires a little different IV hydration, for instance, because what you're going to need to really get at it, the primary need here, is to fill this intracellular space. And how would you do that? Do you remember? You might need to give some hypotonic solutions here to rehydrate this intracellular space. Why that does that? Rehydrate this intracellular space with a hypotonic fluid initially, and then you'll begin to capture this self-regulation between the ICF and the ECF again. So just something to think about. Not as common as your garden variety dehydration. As I said, one of the number 1 causes is DKA. With hyperglycemia, you have glucose loss of urine, which is loaded with glucose, and it causes a profound diuresis. And then you end up with cellular dehydration. Fever can also cause it. and 2 feedings without water supplementation. As I said, the treatment is hypotonic solutions. So what are the signs and symptoms of hypovolemia? Neurologically, patients become confused. They can even have seizures, particularly if it starts to cause sodium abnormalities. Cardiovascularly, they have tachycardia. And as I said, also orthostasis. Renally, they can have oliguria, which is defined as less than 30 cc's per minute. Per hour. And daily weights obviously will help you to figure out. One cute little tidbit is 1 liter of urine weighs 1 kilogram. So you can sort of begin to figure out what their weight was when they came in and what they are now in terms of their loss of body weight. Patients usually do not become thirsty unless they have 2% loss of total body water. Here you start to see weight loss at about 5 to 10%. Skin and mucous membranes, they become thirsty. This thirst is actually blunted in elders, so they can actually become quite dehydrated and not even feel thirsty. And of course, eventually, hypovolemia can lead to decreased blood pressure, which is shock when you have greater than 40% loss of your intravascular volume. And here, as I talked about earlier, the hematocrit may be high due to decreased serum volume. There's also an increased risk for platelet clumping if the hematocrit is too high, not enough plasma. Hematocrit could be low if they're bleeding, and the hypovolemia is associated with that. Electrolytes may seem high, they may be hemoconcentrated. One of the number one things you'll see in the labs is that the BUN is high. Absolutely. If you see a high BUN and the creatinine is normal, think dehydration. And the urine specific gravity would be absolutely increased. It's just mud. It's thick mud. It's really, really heavy. So then I think we'll talk a little bit about electrolytes in class. So I'm going to highlight this. You should really be familiar with the relationship between sodium and potassium in the intracellular and extracellular space. Know that when we draw blood, we draw it from the extracellular space. The serum is extracellular. From that extracellular value of 3.5 to 5, for instance, we're making huge assumptions on the intracellular, which is the greatest supply of potassium. Therefore, any small deficits in the serum potassium, say 3.2, 3.0, you have large intracellular losses. So that's why you need to have strict adherence to this 3.5 and 5 of these patients. I think everybody pretty much here knows what hypokalemia and hyperkalemia is. Signs and symptoms are very similar. They're both related to muscular loss, muscular weakness. Here's some sources of potassium. Each of papayas. Oral supplements, I think a lot of you have already given them. They're huge pills. It tastes awful. Better to supplement with diet if possible. Here's that picture I was telling you about the sources of potassium. It's only 1 to 2% is what we're actually drawing upon. And that value, we're making these assumptions on this potassium here. So small levels of 3.0, 3.2 are critically important. I mean, massive losses intracellularly. Now, when you have hypokalemia, you can often sometimes have these things that are called U waves. I think I've only seen them once in my life, but there's pictures here of them. They're just a little bump after the T wave. There's your P, Q, R, S, and there's your T wave. There's a little bump after the T wave that doesn't belong there. There's a little bump there, a little bump there. So those are indicative of hypokalemia. Much harder to see than these. These are very prevalent. Normally your QRS, nice here. This T wave should not be any more than 2/3 or 1/3 rather the height of your upward stroke of your PQRS. So therefore, this is a peak T wave, and if you ever see those, they definitely will have a high potassium. Very commonly seen in renal patients. So definitely get the potassium if you see this. Sodium, I'm going to let you follow up on that. I think that's okay. Yeah, it's pretty straightforward. And here's where when we were talking about tonicity earlier, why do we care about that? Is it just an academic exercise? No, because different IV fluids come in different concentrations to treat the different situations that we saw with tonicity. So I've listed here for you the IV fluids, the common fluids, whether they're hypertonic, hypotonic, and isotonic. I wouldn't expect you to know which they are, but do follow through with this exercise so you can begin to understand why we have different concentrations of sodium. And I think this is very self-explanatory. Chloride is really largely just matched with sodium, as you well know, sodium chloride, and largely important for the maintenance of acid-base balance. Also fosters release of CO2 in the lungs and is a component of gastric juice. Calcium, we'll talk a little more as we move forward this semester later on, but it's normally 9 to 11. Hypokalemia, hypo or low levels of calcium. Patients are at risk for seizure, and it's very hard to get an elevated calcium level. The body is very, very well designed for maintenance of the calcium not to exceed the 11 or 12 milligrams per deciliter. A common finding with elevated levels of calcium is cancer, so one should always be scrupulous to look for that. And that is the end of the show. I hope you enjoyed this little module, and I look forward to your feedback. And thank you very much. And I will see you in the next module for the next series in this module on cellular biology. Thank you.